It's good to be home. It's feel refreshing. Unfortunately, there are no people. I was hoping to see a lot of people and then a lot of interaction. Our presentation will be a little bit longer. So what we're gonna do is better to start early. And then let's get started.
Good morning. Okay, I'm Dr. Mwepeng. I'll be presenting the grand round, the case. A 28-year-old para-2 gravida 3 presented at RK Khan Hospital Labor Ward at 10 p.m. with a history of diarrhea and vomiting associated with generalized abdominal pains. How would you obtain further history?
Doc, you can tell us, how would you obtain further history from this patient?
Right, starts off with the main history when it comes to these complaints. Just to now, as to when the symptoms start, the acute thing or it's been gradual getting over a period of time, and we want to know whether is there any other associated symptoms like fever. And we also want to know if she has taken any medications to relieve these symptoms. And we want to know what makes the symptoms worse. And also inquire other systems like the urinary tract. Is she having symptoms suggestive of infections like dysuria, frequency, and agents of urinary symptoms? That should be some of the other symptoms I want. And then she has para-2 gravida 3. I want to know about the pregnancy state, the last normal period, and to know whether she has been booked or not. She has confirmed the pregnancy. I want to know whether is this pregnancy a planned and accepted pregnancy, or she wants to interfere with the pregnancy. And I want to know whether was it a spontaneous conception or happened as a result of induction or early induction or other techniques. And then I would inquire about gynae history in terms of contraception that she's been using, past infections, PIDs, or any other infection that was treated for, but mainly would be the genital tract. And if she has had any ectopics, but I can see there is not indicated in terms of para-2 gravida 3. Then obstetric history, the past pregnancies, want to know about the mode of deliveries there, the outcomes of the pregnancies, the gestational age, all of that history around that too there. And then medical history also. I would like to know whether this patient is on any medications, chronic medications. She not diabetic, or she HIV, and she adherent to the medications or any other. Surgical history also. Want to know if she has had any surgical history in the past, appendix maybe that was removed in the past, or any other pelvic surgery, she be having adhesions or any other problem. And then social history, is she someone who's using illicit drugs, smoking, history, alcohol? I think that's some of the history there.
Thanks very much. It was well done. We can move on.
Okay, in terms of history, she had a history of diarrhea, nausea, and vomiting associated with generalized abdominal and back pains, 3 days duration. There was no history of spontaneous rupture of membranes, show or PV bleeding, no history of fever or urinary symptoms. There was no travel or use of herbal medication history, no history of previous operations, and no significant social history. Index pregnancy, booking bloods were normal. She booked at the gestational age of about 16 weeks by early ultrasound. She was unsure of her dates. Antenatal care was uneventful. Gestational age at presentation was 24 weeks, 1 day, and she also reported good fetal movements. Previous obstetric history, she had previous NVD ×2 and previous late neonatal death, cause unknown, and 1 alive baby. How would you examine this patient?
Dr. Gumede?
Yes. So we'll start with your general examination of the patient appearance. If she's ill looking, then you look at the color of the skin. If she's pale, then you'll move on to your vital signs. You wanna do your BP, you wanna check your pulse rate, respiration rates, and sets, and also you'll do your GM. And you'll do your bedside test, your urinary dipstick. And then you'll move on to your general examination. So from head to toe, you will look at chest. If she's not in distress, you will listen to the lung pulse. If she has good air intrabilateral, then you do your cardiovascular system. If she has normal heart sounds, then you look also on general examination. What's most important is to check if she's not dehydrated, since she presented with vomiting and diarrhea. So you look at the hydration status of the patient. And also you can check the capillary flow, and you check for any dry mouth and any signs of hydration and skin pinching. And then, sorry, I'm gonna go back to the general examinations. So you look at the abdomen, check if it's a gravid uterus. Is it soft, non-tender? Are there any palpable besides the fetus? Are there any extra palpable masses? And then you check the lie, and you check the presentation, if the abdomen is soft, non-tender, and it was only LAP. You can also check PV if maybe she's not in, so that you exclude that she's not preterm labor. So you wanna check the cervical dilatation, effacement, if there is a show, or maybe there is a PV discharge. And yeah.
Okay, fair enough. We can move on.
Okay, on examination, our patient was clinically ill, restless, dehydrated, and in severe pain. She was pink and there was no lymphadenopathy. She had a blood pressure of 105/53 with a pulse rate of 125, a temperature of 38. She was saturating at 100% per room. BMI was 31.5. Abdominal examination, she was gagging with generalized tenderness, but no rebound tenderness. It was difficult in determining SFH, liquor volume, and presenting part. Speculum exam, there was no PV bleeding or PV discharge or rupture of membranes or any show. She was 2 cm dilated and 1 cm long, with membranes intact on the cervix. Other systems were normal.
Maybe we, because Dr. Zita, I'm not sure whether you had other information. Okay, maybe next. So what are the possible differential diagnoses? We're gonna come back to Dr. Zita.
They can summarize.
No, you can try. Well, what you still got that? We want you to gather yourself. What
Yes, it will be.
Oh, no, let him shine a little bit because you had a notice, yeah.
So it's an acute presentation, and she's, in terms of the vital signs, she's parietal temperature of the 8s.
Maybe you can go to the vitals.
Pulse of 125. So And as per the first line there, describing that she looks ill and dehydrated in severe pain. So this patient, I would think of things like cholecystitis, one of the potentials, appendicitis.
But we're best obstetricians. We can start from our field, our domain where we are more familiar before we move to other domains. As an obstetrician, what will come to your mind first before you move to other people's domain?
I didn't hear the history, but from what I'm seeing here.
Okay, maybe Dr. Gumede can try because she knows the history.
So she's a graph 3 parent 2 at 34 weeks by ultrasound who presented with symptoms of diarrhea and abdominal pain. On examination, she's dehydrated with a tachycardia and she's paroxysmal with a garden and generalized tenderness of abdominal exhalation, and she's 2 centimeters dilated and 1 cm long. So the most likely diagnosis, if I'm looking at all the symptoms, will be she has an acute abdomen based on the guarding and generalized tenderness and the pyrexia and tachycardia. And also she may be preterm labor as well because she's also dilating. I'm not sure whether she has a previous delivery, was it NVD?
Yeah, NVD test.
Oh, okay, so uterine rupture.
Abdomen is the finding, it's not a diagnosis.
Yes.
So what are you looking at? She's pyrexia,
She may be having a uterine rupture as well.
uterine rupture gives you pyrexia.
No, it won't give the pyrexia.
She presented with diarrhea, if I remember, and abdominal pain. She now has an acute looking abdomen with some pyrexia and tachycardia, lowish blood pressure. That's focal. That preterm labor could be secondary to the whatever is happening. So focus there and am I lying ahead of her? Okay.
Yeah.
So for pregnancy related, so I'll put an acute abdomen, maybe a cholecystitis. And then non-gynae causes could be acute appendicitis.
Appendicitis gives you pyrexia, I mean, it gives you diarrhea.
It gives you pyrexia, yes, it does.
Yeah, it gives you pyrexia, but does it give you diarrhea?
Yes, as a pre-symptoms preceding to the infection, it does.
And then pyrexia with the appendicitis, is it always or sometimes?
Sometimes, not all the time.
Yeah, so it's not always with the appendicitis, the pyrexia. Dr. Zita, I'm not sure whether you said ruptured uterus and then cholecystitis.
Maybe she has an adnexal mass.
Adnexal mass. What do you mean by adnexal mass?
She may be having a ruptured hemorrhagic cyst.
Okay.
Yeah.
Come again, Dr. Gumede.
I was saying maybe she has an adnexal mass.
34 weeks.
Yeah, so you say a ruptured hemorrhagic cyst. Oh, okay.
No, Dr. Chonke, you can't just say okay.
Hi, Prof. Can I try?
Who's there?
Dr. Zuza? I could not make it to the meeting. I have a slate today, Prof. Albert.
All right.
My first on the differentials would be maybe she's having acute chorioamnionitis. Looking at the fact that she's pregnant, she has signs suggestive of infection. She has acute abdomen and she has sepsis.
Diarrhea and vomiting. Does acute chorioamnionitis.
It could be as a sign of overt sepsis as well.
No, sepsis doesn't give you the information. Okay, let's say Dr. Zita. Second differential is fine. Let's say, yeah, second differential, chorioamnitis. Second,
Yeah,
no, let's ask Dr. Online. Second differential, please. She's gone. Second differential, please. Nzunza.
Yes, acute gastroenteritis as well could still be a differential. She's vomiting and she has diarrhea.
Yeah, but we such the sign suggestive of acute abdomen.
That's still remains number one. She can still perforate from some IBS, or she has some ulcerative colitis that they. Yeah, so that should be your first thing.
Oh, okay, Dr. Zita.
yeah, I think I would have also obstetrics, I would have gone with the chorioamnitis, although she hasn't ruptured membranes or anything. And then gynae, unlikely to be a tubal ovarian complex with some previous history of PID. And then gastrointestinal would be cholangitis, cholecystitis, or pancreatitis, and also perforated ulcer.
Oh, okay. Yeah, we can move on with our differentials.
Okay, these are our differential. Ruptured.
You also start with ruptured uterus.
Yeah, that's what we thought, because the symptoms are not leaking with the ruptured uterus, but the clinical examination, except the pulse, it could be related to, yeah, it could be linked with the ruptured uterus.
The duration was for 3 days
Yeah, 3 days duration.
and the babies are alive.
The
Yeah,
baby is alive.
The baby's alive.
Actually, on arrival, also the CTG was done. So then the CTG was pathological. So because of the clinical picture, the first differential was abruptia placentae. Then the patient was actually then booked for Caesar as well.
Okay, I think okay, it's fine. So our second differential, it was the ovarian cyst accidents. So with ovarian cyst accidents, the symptoms, nausea and vomiting, they might present with nausea and vomiting, and then the clinical picture as well. But the temperature is not tying up. When you look at the appendicitis, which is non-gynecological, the signs and symptoms can be linked with the appendicitis. And then with appendicitis, we expect that they might have a rebound tenderness. And then, but it was more to a generalized tenderness. Chorioamnitis, signs and symptoms not tying up, but the signs are they could be more suggestive of that. So abruptio, because we say it's a live baby, so it's less likely if she was going to be grade 2, and grade 2 they come with the soft non-tender abdomen.
I think the danger we are doing one is that you are presenting because you know something. You are coming from behind. You are not coming from before. You need to work with the patient to say at this point these are. And the danger we have made here is that you have not summarized your real key features. She presented with this, and I found that. And at this point, this is the most. Now you're already giving us investigation, CTG. You've got background information that we don't, and that's why you listed your things. Probably we're going to end up on a ruptured uterus somewhere. I don't know, but that's not, maybe, I'm saying, as you as a presenter and you and Dr. Chauke, you are coming from that side. You need to work with the patient. On arrival, she presented with this, and I found that. And at this point, this is the summary of my presenting complaint and findings. And that is why before any patient, you must have a summary of your findings and a differential at that point. Because it is the differential that you are going to change with your investigation. Now you're already telling us at some point, CT was this, just an investigation, you are following.
Yeah.
You remember when we teach 4th years, we tell them history, summarize the history. Exam, summarize your history plus exam, then come up with a differential. Then your investigations must exclude your differentials.
Yeah, it's fine. For the sake of time, well, we're gonna go to investigations and then we're gonna come back to our differential and exhaustive. Okay. Can we proceed?
How would you investigate this patient?
Let's say Dr. Gumede, investigations.
Hi, sorry, can I just interject before you move on to investigations? I'm just concerned with the registrars, it's Dr. Naika here, that no one has identified that this patient is in shock and then differentiate between which type of shock, and that should assist with their differentials and even with the acute management of this patient before trying to make the definitive diagnosis.
Okay, thanks very much for the comment. I think almost everyone will agree that the patient had some sort of acute abdomen. Yeah, you can proceed.
Sorry, no, I'm not referring to the acute abdomen, Dr. Chauke. I'm just talking about the patient's clinical condition with her vitals and her blood pressure. So that makes her in shock. So before you even jump to whether it's from an acute abdomen or APH or whatever the cause, or even non-gynecological reasons for shock, that was the first step, and they should have immediate management before they move on. And none of them, they all went to what is the cause of the patient being ill, but didn't recognize that she's in shock and which type of shock.
Okay, thanks very much. Dr. Gumede, investigations.
So I'll start with blood investigation. So I'll do a full blood count, interested in looking at the white cell counts of this patient and the hemoglobin levels and the platelets. Then I'll do UNE to look at the renal function. And also I would like to do an arterial blood gas to look at the metabolic status of the patient. And also I think the liver function test as well. We can do them in this case since she presented with GIT symptoms, so that we can see if there's any abnormalities on her liver function test. And then moving on to also we'll send urine for MCNS. And for images, I would like to have abdominal ultrasound.
Remember, she came 10 p.m.
10 p.m.
in the evening.
Okay, I can do a bedside obstetric ultrasound on her.
Good.
Just to check on the fetus. And what else can you do?
Yeah, features and other things, ultrasound.
Once she's stable, we can also do CT.
Yeah, but the pelvic ultrasound, you check for features and other things.
I'll check if there's any other signs of maybe ruptured appendix.
Cool.
Or maybe if there's any fluid in the abdomen.
Oh, okay. Any other investigations, Dr. Masonde? She spoke about urine dipstick, blood FBC, UNE, yeah, arterial blood gas, and then bedside ultrasound because it's in the evening. Okay, for the sake of time, we can move.
Okay, the investigations done, there was a urine dipstick. There were ketone 2+, leukocytes 2+, and blood 1+, and a blood gas a pH of 7.30, a lactate of 3.2, base excess of -8.2, and a backup of 18.2 with a PCO2 of 37 millimeter of mercury. White cell count was 21.2 with an HB of 11, platelets 340. The urea sodium was 134 with a potassium of 4.2. Creatinine 27 and urea 1.5. CRP was 294. Bedside ultrasound, there was an intrauterine pregnancy, fundal placenta, LICA adequate, a fetal heart rate of 185 beats per minute, no adnexal masses. There was fluid throughout the pelvis and abdomen noted.
Dr. Masondo no, Dr. Zita can interpret the result for us. And then Dr. Masondo, you can tell us what are the possible diagnoses.
Can you just find out about the GM?
The GM was normal.
GM was normal. Okay, so on the urine dipsticks, they have leukocytes, blood and ketones, which could suggest a urinary tract infection. The blood gases.
And then what do you say about the ketones?
The ketones, I don't know when last this patient had something to eat, that they've been vomiting, so
it's keeping with the history.
it's in keeping with the history.
Yeah.
The blood gas is showing lactic acidosis, with low pH and high lactate. The low the bicarb is on the left side, and she has elevated inflammatory markers, including the white cell and CRP, which might be pointing more to an appendicitis in this case. The UNA is normal. The ultrasound, so it's just that we have a fetal tachycardia there on the, that's the CCG, right? On the ultrasound.
No, that's the
It's on the scan. Yeah, the ultrasound seems to be, and there's fluid throughout the abdomen. So there's a collection in the abdomen, there's elevated inflammatory markers, acidotic picture. So, yeah.
Acidotic picture, respiratory or metabolic, and why?
Metabolic, because the PCO2 is not low.
Yeah, it's normal, or yeah, it's normal and it's not high, not low. Oh, okay, Dr. Masondo, now let's come to back to the differential diagnosis. Now we've got a better picture now. From the history, exam, and then we've got the investigations. 10 p.m. I'm just looking for your conviction now.
I think again, yeah, it's an acute abdomen. Now I'm just wondering where this fluid is coming from in the abdomen. It could be
What could be the cause of this?
That could have ruptured. Yeah.
Okay, then let's Dr. Masondo
Be an
shine a
acute
little.
appendix. I guess rupture.
Okay,
Ruptured-
one
ruptured-
ruptured appendicitis and
Yeah,
other
so-
differential. Is ruptured uterus likely or unlikely, and why?
Ruptured uterus is unlikely.
Why?
Because this patient has been paid for past 3 days, and there's no, also there are no risk factors for uterine rupture in this pregnant. This patient, she was delivered previously NBT times 2, and yeah, it doesn't come with these raised inflammatory markers, and the temperature is so high, the baby is alive. So if you know the uterine rupture, you have no signs of infection like this, and the baby might be.
And other things for against the rupture. What do you say about the HP?
And the hemoglobin, yeah, they will have a drop in hemoglobin because of the doctor.
Okay, any other differential? That's more likely.
Hi, it's Dr. Khatebe. Hi.
Yeah.
Yeah. Very low on the list would be a non-gynae pathology, surgical pathology would be a ruptured diverticular disease with sepsis and pus in the abdomen. That could cause the metabolic acidosis, a high lactate, and with fetal affectation.
And then what's the gynae condition that can mimic this kind of picture?
Right.
Dr. Gumede, can go your possible differentials. Dr. Gumede, any gynae condition that can mimic this kind of picture? Hold in the pelvis, patient with acute abdomen. Okay, yeah, for the sake of time, because we don't have time. Yeah, okay.
A cyst accident with secondary infection.
Yeah, accident.
A cyst accident with torsion, rupture, torsion and rupture.
Oh, no problem.
Can give you pyrexia and a high inflammatory markers, metabolic acidosis, and a high lactate.
Okay, no problem. It's fine. Yeah, I can proceed.
Okay. Thanks. So, ruptured appendicitis or ruptured ovarian cyst, symptoms and physical exam with wrist septic markers and pelvic abdominal collection, ruptured uterus and abruptia placenta, less likely, atypical presentation, patient had normal HbN platelets with wrist septic markers, and in the pelvic abdominal collection may be associated with uterine rupture. How would you manage this patient?
Dr. Zita?
Yeah, so this patient has, we're thinking she has a ruptured appendix. She's pregnant for 34 weeks. So the best thing is to initiate the septic 6 bundles. So I need to ensure within the first hour that she has an IV line, start on IV fluids, insert a catheter, monitor the input and output, and do blood cultures and start her on a broad spectrum antibiotics after the blood cultures.
No, you're doing very well. Yeah.
So within the first hour, that's what I want to do. This is a patient who will need at the minimum a high care and possibly the ICU. So it's a multidisciplinary approach in managing her. I need to get the hands on deck. So inform my anesthetic team, check my ICU team if they have a bed, and inform PEDS because we might need to deliver. But first I need to stabilize her and monitor the lactate and counsel her about the condition and the management.
Yeah, so you didn't say anything about the surgical intervention involving the surgeons as well?
Yeah, the surgeons as
well.
Yes. We have an acute ruptured appendicitis, so she will need an exploration.
So how would you counsel the patient, more especially if you're not sure about the diagnosis, because we're not sure whether it's ovarian cyst accident or it could be ruptured appendicitis?
Yeah, so you counsel on the differential diagnosis for a midline, which might need to be converted to super umbilical, and exploration and consent for cystectomy or appendectomy, appendectomy, and possibly a cholecystectomy if you find the issues with your cholecystectomy. So she must consent for all of this, and then because we were thinking also on the obstetric side, a uterine rupture, for example, She must also consent for hysterectomy. So if, for example, we take in and fight if there's a rupture of the uterus, and for example, that Albert just had a case like that, but it didn't go to but she must consent for that as well.
Are you gonna go in or is the surgeons who are going in?
I'm gonna go with the surgeons.
Yeah, they must come see the patient first and foremost. The most likely thing here is a surgical problem that just happens to be pregnant. So they need to make a decision that we think our baby is inside the uterus. That's where we came from. Yes, you are considering other adnexal methods that could have done whatever, which were never picked up at the scan. She's been booked and she's been stable. So the surgeons must be there and take ownership, I think, before we go in and stabilize the patient hemodynamically.
Okay, for the sake of time, we can just move on. Yeah, this is so even if the ruptured uterus is highly unlikely, but you still need to take the consent for TAH. It might depend that you go in, the uterus is ruptured, you didn't take the consent, and then you can't even repair.
Full resuscitation of the patient is important. Counseling about diagnosis uncertainty, consent for exploratory laparotomy and possible complications. Avoid fetal TG monitoring in sick and unstable patient. Once the patient is stable for theater, also counsel about the risk of post-operative preterm labor and intrauterine death. And then intra-op findings, there was a ruptured gangrenous appendix that was found with a 4-quadrant pus collection and an appendicectomy. Sorry, Doc.
To me, this is like from the history, it's just a GI problem and acute abdomen. But she's 34 weeks. Before going into the surgery which she needs for the acute abdomen, was the plan to deliver the baby as part of this operation? Or was the plan to just deal with the appendix or whatever it is and leave the pregnancy?
Yeah, so
that needed to be discussed with the patient beforehand. Because the baby is probably of 2 kilograms or so. What was the thinking before you entered? Were you planning to do a Caesar? Or were you planning to just get rid of the pus and the surgeons deal with the bowel and then close the abdomen and continue with the pregnancy?
Yeah. So the initial we're not when we went in, we're not 100% sure of what's the diagnosis, whether it's a rupture or accident.
Let's put the rupture aside because I don't really see the
No, not the uterine rupture, the ovarian.
But with regard to the pregnancy,
Yeah.
Was the plan to deliver the baby at this operation, or if let's assume the uterus is still intact, to just leave the pregnancy and allow her to continue the pregnancy after this operation?
Yeah, so the plan was to allow the pregnancy to continue if it's not there's no obstetric indication to deliver.
Well, because I heard someone saying the CTG was pathological.
Yeah, so what happened after stabilizing the mother, somehow someone did the CTG and then we found it to be pathological. That given us the opportunity to even deliver, but the principle is not necessary to just go and deliver preterm baby and the son. It's just to go and then address the surgical issue. And then once the surgical issue is addressed, you know, you still need to counsel the mother that there's a risk for preterm delivery. Or if it's still, you know, if not a viable pregnancy, a risk of miscarriage as well.
So were the surgeons there or they were called intra-op? Did you see the patient pre-op?
Yeah, so surgeons, unfortunately, they didn't see the patient pre-op because we didn't think, you know, in that line.
Yeah, I think really whoever managed this patient, and sorry to take this off, I think here we're creating a scenario. But I think as a unit, you need to look at how this patient was managed. Why were the surgeons? I know our kind of challenges with other domains, the surgeons in particular. But you can't have a surgical case and we are not entertaining, number one. And we are not even calling the people who, usually they come and wash their hands, you know, they come and claim that it's not their case, even if we know it's their case. But it looks like here we didn't entertain something that was really, we pursued ops or gynae course when there were many other markers that said something else. Whether this patient was discussed with a consultant, I don't know. Or did the patient manage, the registrar manage the patient themselves? It's 10 o'clock, yes, we understand, but patient like this cannot be taken to theater and a discussion has not been done. The senior has not at least reviewed the patient, even if it's telephonic. Surgeon should have been called. We can't just, Dr. Chauke, I'm sorry to belabor the point. This is not correct.
Okay, for the sake of time.
Sorry, can I make a comment? I think you've got an interesting case, and this is something that we not infrequently may see. Obviously, the timing seems to be an issue, but from the outset, I think I'm keep on hearing this resuscitation. All right, here you have a patient. I understand she's got a tachycardia. Her blood pressure is not low. 105/60 or something like that in pregnancy would be acceptable. All right, we know that she's got what appears to be an acute abdomen. Her hemoglobin is fine. So it's unlikely she's got a bleeding episode. We know there is an inflammatory or infective process occurring. In terms of an acute abdomen and the fact that you did an ultrasound and you found collections in the patient, this warrants, I would say, a drip, antibiotics, senior anesthetist, a laparotomy, and a midline incision. Of importance, and I think that's, as mentioned, yes, the surgeons should be on hand or they should be informed prior to you entering into this abdomen. You should counsel for a midline incision. And Dr. Moran brings a very valid point. It should be made known to the patient. If there is no uterine pathology, then you will continue with the pregnancy. As you entertain, it could be a uterine rupture, or you could be a problem, arising from that uterus. Then the issue changes. And in that case, you may need to expedite delivery. So I think these things need to be done, and you should have an ICU or high care set up post-operatively. But I think this word of resuscitation, I'm still confused what you mean. We know you have to give antibiotics. We know you have to have a drip up on this patient, right? But I'm not that convinced this patient is in impending shock or anything like that.
It's about systolic, the inflammatory, not inflammatory, she's got acidosis, is shock.
Yeah, but okay. You got a pulse rate. Hold on, you got a pulse rate of 125. Your blood pressure is 105 or 65. Your hemoglobin is 5. The issue around the white cells elevated and the CRP elevated, that will tell you there's an inflammatory process, which is most probably infective in origin. But besides putting up a drip, going on antibiotics, I don't know what else I would do in this patient. Most will probably go to the central venous pressure line.
Yeah.
Okay, for the sake of time, so that we can go to our next presentation. Since I arrived to Ake Khan, this was our second case. The first case, I think she came, she was around 12 weeks. We saw her at the clinic. We treated her as a UTI. She came back the second day, and then we said bowel obstruction, and then the surgeons, they got involved. We took her to theater, and we found that she had a ruptured appendix as well. And then 2 days later, she had a miscarriage. And after that, she had multiple relapse, maybe 4 or 5. And then the family, they're suing us for roughly 10 million. And the reason for that, one is the delay diagnosis. And then 2 is for multiple operations. And then 3, they say it's because of the, emotional trauma, seeing their relatives, in pain. So the reason we brought this case, we wanted to highlight the challenges of diagnosing appendicitis in pregnancy. If you go to all the literature, they will tell you that it's difficult because of the, anatomy of pregnancy. Secondly, these cases, they rupture easily. Why? Because the omentum is supposed to be the one that localizing the infection. So if you can't localize the infection because of the anatomical effect of pregnancy, so those cases are at risk or prone to rupturing. I think there were a lot of comments, and then we've got roughly 14 minutes, and we've got a little bit long presentation. Maybe we're gonna go through halfway.
Can I ask?
Question while we setting up for the presentation.
Sorry, can I ask a question? You're saying the family is pursuing a litigation on this particular patient. All right. Do you...
No. This one, the other one. This one, the outcome, the baby and the mother, they are at home. They were fit for this life before.
Okay, now that's fine, yeah.
Yeah.
The other thing, Dr. Chauke, is that when you give the blood gas, you don't have an oxygen value there. There's no PO2 when you give the result. To me, that's most important. Your pH, and then you go for your PO2. When you gave the results on the on your presentation.
The PO2 was normal and the CO2.
But I'm still not taken aback that you still want to resuscitate. I don't understand this resuscitate. Your UNE is normal. No, I mean what I'm saying. Your UNE is normal. All right. Your blood pressure is 105/60. Your pulse rate is 125. We know she's got an acute abdomen, and you know she's got a collection. You should start the patient on antibiotics, have a drip up. You can put a Foley's to monitor urine output, but I won't sit with this patient.
Okay, thanks very much. We're gonna go for the second presentation. So as you can see that if you are 10 p.m. you're at the hospital now, it's much more easier because we're looking at the case in retrospect. But if you are on the ground, it's a little bit sometimes a challenge. Thanks very much, Dr.
Chauke. Just one last thing, on Dr. Moran's point about the pathological CCG. With the severity of the mother's condition that she was, you need to counsel the mom that the baby may still be affected because of the severe acidosis and the affectation of the baby. Even though we've corrected, because of how long she was ill, there may be an affectation of the child. So we still got to warn it that the baby may still be affected because of the prolonged acidosis and the maternal condition. So if the baby is recovered, you may still have some residual damage. So we just need to highlight that. So even though CCG and everything is recovered, you need to warn the mother baby can be a problem after delivery.
Yeah, I think the mother was concerned about the risk of preterm labor and then IUD as well. I think we did cancel. I'm not sure whether it's African problem where you find that a patient comes with the asthmatic attack and then all of a sudden, you see the patient and then when you're done, the nurses, they don't come, sometimes without even asking. And you find that the mother is still difficult. They just put the CTG and people, when they see deceleration, sometimes they take that CTG and throw in the bin. Or if they are honest, they'll show you, doctor, unfortunately, I did the CTG and this is a problem. And the mother is sick. Like this kind of patient, ultrasound auscultation was more than enough to me, as long as you cancel the patient. But if somebody, they come and they put the CTG, you can't look at the other side because it becomes ethical and moral issue if you neglect.
So Dr. Chauke, the story sort of was cut off suddenly. What happened in the operation? Did she get better? And how's the baby now? Is she born or is she still pregnant and the baby's fine?
The mother and the baby were discharged before, so they were fine.
And she came back and delivered, or how did
No, she had a seizure. That's the part too.
So the baby was delivered intra-op.
The baby was delivered intra-op.
Any reason? Or because of that CT?
Yeah,
I thought you said you were not going to touch the baby.
Sorry?
I thought you said you were not going to touch the baby.
That's the initial plan. Initial plan was to not to deliver preterm baby. But unfortunately, if somebody they put the CTG, you can't ignore the CTG. Tomorrow the mother can come and then say, it's true I was sick, but my baby was in trouble and they didn't deliver my baby. Now my baby's got some issue. And then most of them, they will tell you that I was willing to sacrifice myself for the baby. And then all of a sudden, they've got a room to litigate you. So maybe they can tell you it would be much more better for me to die.
You didn't show us the CTG because all we had was tachycardia. Because tachycardia was in line with the pyrexia as well. What was it actually? I mean, was the variability poor or?
It was
Decelerations?
It was spontaneous decelerations.
Can I just make a comment? I think Dr. Moran is bringing up a very, again, valid point. When you have a patient with sepsis and you're getting pus in that abdomen, do you start opening new tissue planes, especially on the uterus?
Yeah.
All right. So if in any way it's got a fetal tachycardia, we'll accept that. The mother has got a tachycardia as well. So that will give an explanation for that. And obviously, my honest feeling would be not to expedite delivery via making an incision in that uterus, unless it was truly pathological, and then you discuss with the mother that there are problems that you can obviously spread the sepsis if you do find it in the body, because once you get into the uterus and you get sepsis in that uterus, the probabilities of losing that uterus will be high going forward. So I think here we're lucky, we got away, but I think it's very important to really make your decision on expediting delivery depending on what you find on that CTG. At fetal tachycardia in this scenario, to me, is not pathological.
Yeah, the issue was not tachycardia. Tachycardia, we would have accepted that the CTG was it was spontaneous decelerations. It was something that you could not ignore. I'm not sure whether we've got 6 minutes and then we've got the 32 slides. I'm not sure whether we can proceed with this or we just call it a day, because as you can see, that the case was not easy and then simple forward. And then even the one that they litigated us, we've been sitting with the surgeons and the lawyers and all the stuff. You can see that we brought the literature and all the stuff. Even the surgeons, they agree that, that's not an easy case to diagnose. Even that patient that we took in, the one that demised, it was we took her in as a bowel obstruction.
Sorry, Dr. Chauke, can you just present the principle of management on your slide? Just go to the principle of management of appendicitis in pregnancy, because I'm sure we all don't have an idea of how to manage those patients. And in the years gone by, most patients lost babies because of how patients were managed with ruptured appendicitis.
Okay, thanks, Dr. Maisa. We're going to go straight to management. Yeah, let's start from management then.
All right. So in terms of management, the British Society for Gynecological Endoscopy, as well as European Association for Endoscopic Surgery, both recommend operative management in pregnancy. The evidence for this is the higher maternal and fetal morbidity and mortality with conservative management. So the surgical exploration is indicated in all suspected cases of acute appendicitis in pregnancy. But patients have to be counseled about the high rate of negative laparotomy, which increases with gestational age and is higher in pregnant patients, which is nevertheless minimal compared to the risk of delayed treatment of appendicitis. But because of the high risk of perforation in pregnancy, so the approach would be surgical. And a delay in surgery of more than 24 hours increases the rate of perforation to 66%. So as we said, conservative management is not recommended due to high rates of perforation, peritonitis, fetal loss, and recurrent appendicitis. So conservative management, fluid infusion, bowel rest, antibiotics are sometimes considered only in very early stages of appendicitis with minimal or very mild symptoms. While the standard of care is appendectomy, a possible reason for why some people still go for conservative is because of the risk of preterm birth and fetal loss associated with doing the surgical procedure. So in terms of the surgical management, preoperative would be bowel rest, IV fluids, and antibiotics coverage. So both second or third generation cephalosporin as well as metronidazole. And those should be continued post-op, especially in cases of gangrene, perforated, or periappendiceal phlegmon. Multidisciplinary approach involving surgeon and anesthetic team, counseling on obstetrics and non-obstetric risk of appendicitis, especially if it's a complicated appendicitis, counseling on operative risk and rate of negative laparotomy as well. So in terms of whether to go for a laparotomy or a laparoscopy, so both the Society of American Gastrointestinal and Endoscopic Surgeons and the European Association for Endoscopic Surgery recommend a laparoscopic approach for patients up to 20 weeks of gestation. The UK guidelines do not recommend laparotomy over laparoscopy or the other way around. So in terms of gestational age, laparoscopy is preferred in the first and second trimester, whereas open appendectomy may be preferred in the third trimester due to the enlarged uterus, making laparoscopic approach more challenging. So it also depends on the surgical skills available at that time and the accessibility to laparoscopic services. But of note, both approaches have similar rate of preterm birth. So with the laparotomy approach, positioning of the patient is important. So the table should be tilted 30 degrees to the left to decrease pressure on the inferior vena cava and facilitate access to the cecum and appendix. So in terms of the incision, it is recommended before 20 weeks to place the incision at the McBurney's point, but after that, at the point of maximum tenderness. And in cases with unsure diagnosis or diffuse peritonitis, a low midline or a right para-umbilical incision can be made. Intra-op, minimal uterine manipulation should be done to reduce the risk of preterm labor, unless decision to do a Caesar at the same time is made. And the decision to do a Caesar would be based on obstetric reasons. In terms of the laparoscopy, it's preferred in the first half of pregnancy. Again, left-sided position, low insufflation pressures, 10 to 12. And intra-op ABG monitoring is also essential. So the advantages, it's useful for the diagnosis, to make the diagnosis, less post-op complication, earlier mobilization, fewer cases of venous thromboembolism, less post-op requirements of opioids, especially in a patient that would still be pregnant, shorter hospital stay. In terms of the disadvantages, it requires advanced surgical skill to operate on a pregnant patient. Carbon dioxide pneumoperitoneum, so there's a decreased uterine blood flow, resulting in fetal acidosis and fetal hypercarbia. Risk of injury to the uterus while inserting the Veress needle, and the risk of preterm labor as well. Special note, with a periappendicular abscess, it could be managed by percutaneous drainage as well under ultrasound guidance, combined with antibiotic therapy in certain cases. In terms of the postoperative care, so preterm contraction is common, but mostly without progression to labor. So tocolytics is not recommended routinely, but can be considered with post-op uterine activity, and continuous fetal monitoring as well post-op if the fetus is viable. Early mobilization, VTE prophylaxis depending on the case profile, and wound care because those patients are especially at risk of wound sepsis. So to conclude, cases of appendicitis in pregnancy require early clinical assessment and multidisciplinary team approach. There's a high rate of negative appendectomies, and the complications associated with surgical intervention warrants a thorough clinical examination and investigation. Diagnostic suspicion should correspond to an early exploration, and a delay in surgery comes with a lot of risks, the risk of perforation, miscarriage, fetal loss, preterm labor, and maternal mortality. That's all from the management board. My side.
Okay, thanks very much. I think we 1 minute, 2 minutes out of time. Maybe one comment before we call it a day.
Can I just comment there? Firstly, thanks to Michael Khan for presenting the case. I think it was a very interesting case with useful discussion and learning opportunity. My comment is that careful assessment of the patient on presentation will tend to lead you to the appropriate diagnosis. Because for me, from the start, this patient was presenting with GIT symptoms. She had vomiting and diarrhea. She had an acute abdomen. Even on investigation, the baby was in the uterus. The LICO was normal. As was said, there were no risk factors for rupture of the uterus. She wasn't even in labor as far as we know. So I think we were looking at a surgical problem for the surgeons. I don't think, you know, despite all the discussion, she went to theatre the same night, didn't she?
Yeah.
So it wasn't that there was a delayed diagnosis. I find it very sort of you know, unrealistic in the presentation to say we should have a high index of suspicion and do surgery whenever we might suspect appendicitis. I mean, I've never heard of us doing laparotomies or laparoscopy for suspected unruptured appendicitis in pregnancy. I'm not quite sure what they're trying to suggest. Every time somebody comes with a bit of low abdominal pain, we must exclude appendicitis through surgery, because I don't think that's really very practical advice. I think here, as soon as you get signs of an acute abdomen, then obviously you have to go in. And I think you did in this case. You know, I don't think there was a major delay from what I'm understanding. It's not just appendicitis. We've had maternal deaths that I've you know, seen the files of in the province, where there was spontaneous or apparently spontaneous perforations of other parts of the bowel as well, with peritonitis. I mean, as long as the person presents with those signs and symptoms, you'll have to go in.
Thanks very much, Dr. Moran, and then well done for the girls. Keep it up. Enjoy the rest of the day. Dr. Zita? Yeah. Oh, okay, thanks very much. What's that?
Recording stopped.
No.